Welcome to Renus Care Radio. Anemia is a common complication of chronic kidney disease, CKD, affecting a significant portion of patients as their kidney function declines. This episode explores the pathophysiological mechanisms behind anemia in CKD, outlines the current diagnostic criteria and approaches, and reviews the latest treatment strategies aimed at managing this condition effectively. As renal function declines, the incidence of anemia increases, significantly impacting the morbidity and mortality rates among these patients. Anemia in CKD is multifactorial, primarily driven by decreased erythropoietin production, iron deficiency, and inflammation. The pathophysiology of anemia in CKD is dominated by three main factors: reduced erythropoietin production, iron deficiency, and inflammation-induced changes in iron homeostasis and erythropoiesis. Normally, the kidneys produce erythropoietin in response to hypoxia, stimulating red blood cell production in the bone marrow. In CKD, damaged nephrons lose the ability to produce adequate amounts of erythropoietin, leading to insufficient erythropoiesis. Furthermore, CKD often leads to iron deficiency, which results from a combination of factors including poor gastrointestinal absorption, frequent blood losses, often from hemodialysis, and reduced dietary intake. Additionally, inflammation common in CKD increases hepcidin levels, a hormone that inhibits iron absorption and traps iron in storage sites, further complicating anemia management. Diagnosing anemia in CKD involves a thorough evaluation to confirm the presence of anemia and to identify its etiology. According to the Kidney Disease, Improving Global Outcomes, KDIGO, guidelines, anemia is suspected when hemoglobin levels fall below 13 grams per deciliter in men and 12 grams per deciliter in women. The diagnostic workup includes a complete blood count, CBC, to assess hemoglobin levels and red blood cell indices, reticulocyte count to evaluate bone marrow activity, and serum ferritin and transferrin saturation to assess iron status. Additional tests may include vitamin B12 and folate levels, especially if macrocytosis is present. In some cases, a bone marrow biopsy may be necessary to rule out other causes of anemia. The treatment of anemia in CKD is tailored to address its specific causes, namely the following four approaches. Number 1. Erythropoiesis-stimulating agents, ESAs. ESAs are commonly used to treat anemia in CKD by mimicking the action of erythropoietin. While effective, their use requires careful monitoring to avoid potential risks such as hypertension and increased risk of cardiovascular events, which have been associated with higher hemoglobin targets. Number 2. Iron supplementation. Both oral and intravenous iron supplements are used to manage iron deficiency in CKD. Intravenous iron is often preferred in more severe cases due to better efficacy and fewer gastrointestinal side effects compared to oral iron. Number 3. Vitamin supplementation. Treatment may also include supplementation with vitamins like B12 and folic acid, particularly in patients with deficiencies detected during the diagnostic workup. And number 4. Emerging therapies. Recent advancements include the development of hypoxia-inducible factor prolyl hydroxylase inhibitors, HIF-5s, which promote endogenous erythropoietin production and improve iron regulation, presenting a promising alternative to traditional ESAs. Anemia in CKD is a complex clinical issue that significantly affects the quality of life and survival of patients. Understanding its pathophysiology and implementing effective diagnostic and treatment strategies are crucial for managing this condition. Ongoing research and development of new therapeutic agents continue to enhance the management of anemia in CKD, aiming to provide better patient outcomes and reduce the burden of this disease. As treatments evolve, personalized medicine approaches will likely play a crucial role in optimizing anemia management for individual patients, tailoring therapies based on specific pathophysiological findings. Thank you again for joining us here on Renus Care Radio.